Well, good morning. Thank you, Dr. Chapman, Dr. Skillion, and the Planning Committee for this important annual symposium invitation to speak to you today. I think it's very courageous for the Planning Committee to have a medical oncologist as the first speaker at a neurosurgically oriented conference. So again, this underscores Dr. Chapman's earlier point that we're really at a time when multidisciplinary, multi-professional engagement is particularly critical. First of all, again, I'm the executive director of the Swedish Cancer Institute. I've been here in Seattle for roughly 3 years. I'm a medical oncologist who has focused in GI medical oncology, but in particular in early phase drug development. And the message that I want you to take home today from a medical oncology standpoint is that we're really in, it's an overused term, but we are truly in a transformational time in cancer medicine in general and in medical oncology in particular. And why do I say that? I say that because historically, just as surgeons are very focused anatomically for good reason, you want a neurosurgeon working on the central nervous system. From a medical oncology standpoint, historically, we've treated patients according to the site of origin of their cancer. So in general, patients with colon cancer were treated and have been treated in a certain series of ways. Likewise, patients with lung cancer and patients with breast cancer, et cetera. The era that we're slowly evolving into, and we're probably there more than you realize, is that anatomic site of origin is less and less important. And increasingly, we're focused on the unique biological characteristics of the patient's tumor and ultimately of the patient themselves. So that I truly believe within 10, 15 years easily, we'll look back, certainly those of us who have been medical oncologists, and think, boy, that was a little odd that we used to treat everyone based on the site of origin of their tumor. So that's the message, and I hope to show you a little bit of the reason why that is the case, and to lay out a path that is being embarked on not only here at the Swedish Cancer Institute, but around the country and the world. Now, several years ago, we began a strategic planning process at the SCI. I should point out that the Swedish Cancer Institute is an interesting entity. It's one of the older cancer centers in the country, actually. It was founded in 1932 and was the first site for administration of radiation therapy west of the Mississippi. And again, that was in 1932. Swedish Medical Center was founded a little earlier in 1910. But 3 years ago, we embarked on a strategic planning process that was intended to give us a path forward, and we focused on the concept of personalized medicine with a double meaning, with a double entendre. And I know we have an array of professionals in the audience, to include some nurses and probably some pharmacists. And I want to emphasize the double meaning. On the one hand, Swedish in particular as a system has been focused on holistic care, engaging the entire patient and their family, addressing social, psychological, environmental issues. And we have a robust suite of supportive care services, things like survivorship, palliative care, oncophysiatry, psycho-oncology, et cetera, integrative medicine. On the other hand, there's the notion, again, of uniquely characterizing the patient's cancer and understanding the unique biological characteristics of the patient in front of you that has to do with, again, in shorthand, genomic medicine, molecular medicine, if you like. We're going to focus on the latter today, but I want us to understand that double meaning. And again, the basic model of our practice, this is very important, is we're really a hybrid institute. We're a non-university research practice at the Swedish Cancer Institute. And our basic model is the traditional academic model of evidence-based, research-driven, multidisciplinary, meaning the different physician disciplines, different provider disciplines, but also multi-professional, including nursing, pharmacy, social work, et cetera. disease site-oriented, patient-centered care. That is the model that we pursue, and again, with the appropriate team members and discipline members as outlined here. We have a network of 5 hospitals that constitute the Swedish health system within the Greater Providence family. Our Cancer Institute is a network of distributed expertise. We have approximately 200 cancer center members. And of course, we share the neuro-oncology program with our colleagues at the Swedish Neuroscience Institute. We see approximately 7,200 new cancer patients a year, which is a sizable volume of folks, and have 9 multidisciplinary disease site teams, one of those being neuro-oncology, as well as GI, GU, thoracic, et cetera. So that gives you some general notion of who we are, and the disease site-oriented teams are listed here. I think the important concept, again, as we move forward in the 21st century, is the concept of addressing the entire arc of the patient's experience. So it's not just about treating the patient during active disease, but addressing cancer at a population level, and of course with great emphasis on survivorship. Now, what is personalized medicine in the context of genomic medicine or precision medicine or targeted therapy? First of all, it is a disruptive change for the reasons that I talked about. It's certainly for medical oncologists, it's changing the way we see the patient in front of us and the way we think about initiating not only active treatment, but risk assessment and prevention interventions. Biomarkers, again, trying to shift the concept of what is illness. We're trying to identify patients at risk. You'll hear more about that from Nathan Price, and it's a major focus of the Institute for Systems Biology, a new member of the larger Providence family. Big data, I would argue that just as during a past election period, it was the economy, and there was a word or two that followed that. Now it's big data is really the issue, and I'll be talking much about that over time. I think sustainability is the key point. There's some economic and resource issues that surround personalized medicine that are particularly complex, to include the cost of the agents that we identify through targeted approaches. Now, the general principles for genome-based approaches, and my talk today is going to focus on sequencing of DNA, next-generation sequencing, and identifying gene mutations, gene alterations. But there's a larger aspect of biological profiling that includes synthesizing or sequencing of RNA, that is understanding the transcriptome, understanding the expression of proteins, whether through a computed approach or through a measured approach, and also the important nexus with immunophenotyping individuals and their tumors, that is understanding the immune-related profile of a particular cancer. But what are the major objectives in genomic analysis? One is quite simply to, and probably the most popular nowadays, is to look at a gene profile and try to match it with a corresponding agent that we think has a good chance because it's a targeted therapy against that gene alteration. The other is to assess a patient or a population in a prognostic sense and to try to prioritize where treatment is most impactful. And then lastly, in an area that probably requires the most development in terms of day-to-day practice, is using genomic profiling to help in addressing the use of certain drugs or doses of drugs from a pharmacogenetic standpoint. Now, I'm going to tell you a little bit of a history. I mentioned we entered into a strategic planning effort. We came up with this notion of personalized medicine with the double meaning of holistic care and genomic medicine in the personalized medicine context. In March of 2014, we decided, with the adage of not letting perfection be the enemy of progress, we decided to effectively construct our in-house gene alteration panel instead of using an outsourced expertise such as Foundation Medicine or Caris MPI. There are many out there, as you all know. We recruited an excellent team to include Dr. Anna Berry, who was formerly the head of molecular pathology at UCSF, and Anna and Dan Bin Shu, Dr. Shu coming from Mary Claire King's lab over at the University of Washington, helped us assemble what we consider to be a highly actionable NGS panel based on an Illumina platform, a MiSeq platform. And this again was a focused approach using what's considered a hotspot technique, focusing on, again, particular highly actionable, by our definition, gene alterations, and exploring the entire exome relevant to those gene alterations. Again, in March of 2014, this was our initial panel, and based on the evidence in the medical literature as well as input from our broader team of cancer experts. So it was a very interactive process developing this panel. This is the report from our pathology group, Somatics, and it has the customary information that would include the basic demographic data of the patient, the panel. I'm not sure if there's a pointer on this or not. The panel information, that is the basic gene alteration set, as well as sorry, it doesn't work. That's all right. As I said, the basic demographic data at the top of the report, followed by the entire panel description, and then the mutation summary, which is the set of gene alterations for this particular patient, and then a description of the relevant corresponding therapies, both on-label and off-label, as well as, most importantly for us as a research practice, the relevant clinical trials. And then this information is delivered to the clinician in context with some evidence links, as well as a consumer report style weighting of the evidence, if you will. Now, we are in the process of launching a second generation panel, going from 68 gene alterations to 220. I think if you look across the country, you'll find that most institutions are somewhere in this broad range of the high tens to a couple hundred, and there's reason for that, because that's generally where the action is in terms of available agents. I was just in China talking with a very sophisticated group there that's involved in a similar exercise. They have a 22 gene alteration panel because they're referencing the commercially available anti-neoplastics in China, in the Chinese market, on-label agents. So again, for us, the second generation panel of 220, that gap is largely informed by a focus on hematologic malignancies, so that we've broken out a separate hematologic malignancy panel. Again, this is largely evidence-based, informed by sources such as the Cancer Genome Atlas, as well as the prevailing literature, and evidence-based and expert-based guidelines. I won't go into the technical aspects of the panel, but happy to address any questions. And again, just for the record, this is the Somatic panel, that is the somatic, primarily solid tumor aspect of the panel. And then we have a corresponding somatic hematologic malignancy panel. And I emphasize that This is a somatic panel. That is, it's meant to be focused on the tumor tissue and not on germline tissue. With this hotspot technique, we do not look at the germline. There are some who do to subtract out from the somatic information, and again, we can talk about that if you like. Included is a gene fusion panel that's actually an off-the-shelf panel, in this case by Archer. And again, the point is to try to create a set of gene alterations that is most relevant to three areas. One is on-label, commercially available, approved drugs for a given indication. Second is off-label applications that might be appropriate and evidence-based. And third, and most importantly to us as a research practice, clinical trials matching. I mentioned the panel was launched in the spring of 2014. In the fall of 2014, we launched an IRB-approved registration protocol. This was very important to us because on the one hand, we're not telling our clinicians how they should use genomic profiling of their patients' tumors. That would probably be an exercise akin to the proverbial herding of cats. Our more important exercise is to observe, to record how this molecular phenotypic information impacts on a physician's decision-making process, not only whether to use a particular drug, but increasingly whether not to use a particular drug, which is just as important. So the registration protocol, first of all, the physician orders the molecular profiling by medical necessity. And medical necessity is at the physician's judgment. The patient is then offered enrollment onto the registration protocol. And every year, the patient is formally reassessed from the protocol standpoint in the context of their current clinical status and the known molecular profiling. Now, early on, our patients generally are having this molecular profiling as close to diagnosis as possible. This is something that we're doing that's a little different than what's done around the country. For example, Larry would recognize that at MD Anderson, the effort is to use this kind of approach to sort out therapeutic options, whether on clinical trial or not, for advanced stage patients who have already exhausted standard therapies. What we're trying to do is to gather this information as early as possible in the patient's clinical course so that we can begin to put the molecular profiling into the context of the patient's entire arc of experience. And again, that's a little different than what's being done around the country. But the primary purpose of what we're doing is, again, threefold. Two of the purposes have to do with the patient before you. As I've mentioned, one is to prioritize standard of care options in medical oncology. When you have a patient, especially with advanced disease, there's often more than one therapeutic approach that can be justified. Secondly, and most importantly, is for us is the clinical trials matching. And then thirdly, not having to do with the patient in front of you, the use of de-identified data for data mining research. And this is very important as a clinical trialist. I think as clinical trialists, many of us are realizing that in the future, and to some degree now, much of what we used to do through prospective clinical trials can be done, some of that can be achieved by data mining, using large data sets to answer important questions, especially in therapeutic development. The protocol, I just want to emphasize in terms of inclusion criteria, requires that a patient generally have active malignancy, although we do allow for some pre-malignant conditions, and that the patient be a candidate for systemic therapy. So we would not register a patient on protocol who was felt to have a short expected survival. I mentioned that in terms of follow-up of patients, there's a requirement on the protocol that at least once a year, separate from the primary caregiver, that we relook at the patient's molecular phenotype in the context of their updated clinical status to see if there's any therapeutic directional change that should be made based on that information. Right now, this is probably not so important, but moving forward, as we have technologies that allow us to longitudinally follow patients, and some of you know that I'm alluding to liquid biopsies, whether it's assessing freely circulating tumor DNA or freely circulating tumor cells, those will give us the opportunity to not only initially phenotype in a molecular context the patient's tumor, but over time to follow that phenotype to include mutational drift, which is an important subject in systemic therapy. Now, I mentioned we launched the panel in the spring of 2014. We launched the IRB registration protocol in the fall of 2014. We've accrued over 750 patients onto our protocol to date. And then in January of 2015, we launched a molecular tumor board. And again, many centers around the country now have these routinely. These are very much like disease site-oriented tumor boards, except that they're focused on the gene alteration profile of the patient before you and the relevant mechanistic pathways that are being targeted in a therapeutic sense. So our tumor board meets every 2 weeks. We give a basic presentation of the history as we normally would. We do show the light microscopy. This was one of the requests that I had, and not everyone felt that it was necessary. In general, we do not look at radiographic data. That may change over time. What we do focus on, and this is an actual case from April of 2015, is the relevant mechanistic pathways in the context of the identified gene mutations or gene alterations. We put that into context, often through the Cancer Genome Atlas, which basically tells you, for example, this was a patient with squamous cell carcinoma of the lung, and it tells you in general what the experience has been through the US effort and the Cancer Genome Atlas, what is the experience has been in terms of the molecular profile, the gene mutational profile for that particular histologic subset of patients. Then we identify possible therapies, both on-label and off-label, and again, most importantly, focus on possible clinical trials that would be available to the patient, and these are prioritized within our immediate region. Now, the fourth component of the program, which is probably in many ways the most important, is the IT platform. So we actually went through a very exhaustive vetting process and came up with a platform that effectively bolts onto our EPIC electronic medical record. Dr. Rines was telling me about their transition to EPIC as an EMR at MD Anderson. And again, it's one of several common EMRs in the country. The IT platform that we're using for our genomic information is called SciAps. It's a cloud-based, open source, triple store system that can handle semi-structured data, which is important in terms of extracting data from the medical record. But the purpose of this additional bolt-on is basically to collect, to organize, and to analyze the molecular phenotypic data, this molecular profiling data, the genomic data, in the context of the clinical information that's in the electronic medical record. Now, the important point of this IT architecture is that, first of all, in the greater Providence system that we're a part of here at Swedish, we have EPIC throughout the entire system, but each region has a different instance of EPIC. So we use a common enterprise data warehouse that is sort of the generic data set that then interacts with this specialized genomically oriented IT platform. And in addition, and most importantly, this platform is connected to our system-wide clinical trials management system, as well as to our tumor registry. And of course, The tumor registries, while not perfect, because they have a time lag in particular in terms of entering and vetting the data, the tumor registries are arguably the most accurate source of tumor-related information in terms of demographic data in particular. So again, the point of this IT platform is to help us integrate the clinical and molecular data, to help us streamline collection of discrete data to follow outcomes. Clinical trials matching is a key emphasis of our IT effort. And also to integrate in a formal way synoptic data, whether it's from pathology or radiology. So data that can be effectively codified in a standard fashion. We use this IT platform to support our molecular tumor board, and again, we'll be using this moving forward and already are to do data mining research. So some of the information that we gather from this effort is like this. So this represents over 700 of the patients that we've enrolled on our personalized medicine research program at the Swedish Cancer Institute. You can see the number of alterations effectively per patient. So for example, we have 141 patients who have 2 gene alterations in their tumor specimen. This is an array of gene alterations in that same population of patients. And you can see the red relates to applicable gene alterations, which means that there's an off-label indication or a clinical trial that is relevant to the patient's gene alteration, or actionable gene alterations that basically connect to an on-label indication, a drug that's already approved for that particular indication. So you'll see that most of the gene alterations are reflected in red, meaning that most relate to either off-label indications or available clinical trials. And again, this gives you some idea of over 700 patients. For example, you can see that patients with on-label indications include 112 patients with KRAS mutations as an example. Now, the IT platform that we have is integrated into the electronic medical record and includes a basic demographic display, laboratory display, and again, the information that's in the genomic-oriented report to include available on-label agents as well as off-label agents and clinical trials, as I've alluded to. This is an important aspect. Increasingly, when we see patients, what we'll be doing is looking at our regional experience. This is basically a display of patients like the one in front of you. So if you see a patient with a primary brain tumor, a high-grade astrocytoma, and you're wondering, with their particular molecular profile, what has been the experience to date within this data set, this will give you that information. And again, the clinical trials matching is informed by the various particular characteristics of the patient set that you're interested in looking at. So you can interrogate the system for the type of clinical trial eligibility that you're interested in. And this is a similar approach. You can interrogate the system for characteristics based on the tumor registry, based on the initial protocol assessment form, or based on the stage of the patient. Now, I want to finish by emphasizing that we're rolling out this initial genomic initiative at the Swedish Cancer Institute. We're rolling this out through our entire Providence system. So as I mentioned, we see approximately 7,200 new cancer patients a year at the Swedish Cancer Institute. Across all of Providence, we have 34 hospitals, including the 5 at Swedish. We see approximately 25,000 new cancer patients a year. This is over a 5-state region, as you can see: Alaska, Washington, Montana, Oregon, and California. We have a genomics committee, if you will, a genomics initiative that Walter Erba down in Portland and I co-chair. And we have several committee co-chairs who help us with the various relevant areas, bioinformatics, registry repository. We are creating a system-wide biorepository effort, lab specifications, clinical applications, research, and then the business aspects. Our intent is to begin rolling out the 220 gene alteration panel this summer, as well as the IRB-approved registry trial that I briefly described to you. Each region will have a molecular tumor board. We'll be using the same basic IT architecture that I described. And as I mentioned, we will be coordinating a virtual biorepository throughout the entire system. The intent is that by the third year, we'll be enrolling approximately a quarter of all our patients across the broader system. That would be 6,000 patients a year onto this IRB-approved registry protocol. And by year 5, we'd be accruing over half of our patients, roughly 13,000 patients across the entire system. We have a number of key collaborations, one of which you'll hear about this afternoon through Nathan Price, the Institute for Systems Biology, which is basically focused on the concept of systems biology, of biologic profiling, if you will, especially in the context of wellness, and is very much a discovery entity, is now part of the Providence family, and we're going to be collaborating with Lee and Nathan and their colleagues in terms of informing our clinical program that I've just described to you. We also have collaborations with the Hutchinson Institute for Cancer Outcomes Research. One of the important aspects of genomics is the value proposition, and Scott Ramsey and his group are helping us evaluate that. And then lastly, I want to mention important efforts like the ASCO TAPER initiative, which has just been launched. We'll be participating in this effort beginning this summer. They effectively share the same IT platform that we have. And this is a basket trial design where, based on the molecular phenotyping of a patient's tumor, 7 biopharmaceutical entities have contributed at present 17 agents that are connected to certain gene alteration profiles. And the point is that these drugs will be provided to patients. One of the major obstacles is the expensive agents that are identified through this molecular profiling process. And this is really an effort to verify the validity, the feasibility, the validity of matching molecular profiles to associated targeted agents. Now, this is the very last slide. I want to emphasize this is very fresh information. This is effectively the summary of an abstract that's been accepted for presentation at the upcoming ASCO meeting, and was information analyzed from our database by Dr. Tara Benkers, one of our neuro-oncologists here at the SNI and at the SCI, and basically involved looking at almost 100 of our primary CNS tumor patients in the context of this basic molecular profiling. So you can see that mutations were identified in the vast majority of these patients. Particular pathways were prominently identified, in particular in the applicable realm, the realm that's off-label or relevant to clinical trials. And this is just a very early indication of how we'll be using this data. Again, I want to thank my partners in this effort, Phil Gold, who oversees our research effort, Anna Berry, I've mentioned, who's the scientific director of our personalized medicine initiative, Chuck Drescher, who's the PI on the ovarian spore grant and very much involved in molecular targeted therapy, John Pagel, who's head of our hematologic malignancies group, and Dr. Dan Ben-Shu, who's really the technical expert for our panel. Thank you.